So once upon a time, that was not all that long ago, life was simpler, at least in the healthcare arena. You could, go to your doctor, get a prescription, go to your pharmacy, either pay out of pocket or you might have insurance. And if you had insurance, you would pay the copay and you would go on to get healthy and strong, and everybody was happy. Now, that's all very complicated, much more complicated, and much more expensive. I'm Annette Bourbonniere from Nothing Without Us, Stories and Discussions of Meaningful Inclusion. I'd like to remind you that this podcast is captioned and a description. I'm, a 70-ish year old woman. I'm still playing that card. And with short gray hair, dark rimmed eyeglasses, sitting in a power wheelchair, and wearing, I guess I'm wearing earrings here today too. Okay. So if you like this podcast, please, we're coming up on our 1-year anniversary, and it would mean so much to me to have 100 listeners by then. So please subscribe if you haven't. Hit that subscribe button. You can subscribe for free. Give me a like, tell your friends. You can find me on patreon.com/nothingwithoutus. So, but definitely, subscribe yourself and give me some comments. Tell me what you want to hear and who you want to hear from. So my guest today is Matt Olivier, who owns Matt's Local Pharmacy here in Middletown, Rhode Island. And it is unique in this area because it is the only one left that is a sole proprietor. So welcome, Matt. Let's talk about that and the pharmacy benefit manager status. You have to get priors for almost everything because they just don't want to believe that that's the prescription you're supposed to be taking. Obviously, doctors don't know anything, right? I mean, it's kind of confusing here.
It is. It's funny. There were a lot of us independents, even when I opened 6 years ago or 7 years ago, and since then, I think 80% of the independent pharmacies in Rhode Island have closed.
Right.
And I think a big part of that has been the pharmacy benefit manager.
I'm not surprised. Well, that and the whole economic situation when you have big corporations, and I mean, there are two major corporations for pharmacies, and large corporations have a tendency to crowd out the little guy.
They do, especially if they're what they call vertically integrated. So CVS Caremark, they own the whole chain from brick and mortar pharmacy to the insurance company that reimburses us. So they make the rules, and we just have to live by them.
Right. So they own the insurance company, and they also are a pharmacy benefit manager.
They are. Yep. They bought a PBM about 10 years ago.
Yeah. So tell us how pharmacy benefit managers work.
Sure.
I mean, in my view, it's just that somebody says, "Oh, somebody's making too much money in here. Let me go in and I'll help them and myself as well." That's how I view them. But
so they came about at first to work on behalf of the consumer and try to keep the prices at a reasonable rate and drive the prices down to benefit you, the customer. Over time and without regulation, they've now found themselves as what they call a middleman, and their goal is to manage the pharmaceuticals for like your formulary or for what you're receiving, and they're supposed to work in your best interest and get rebates from the manufacturers and keep the price low. But in turn, that's obviously changed over the years, and they seem to be driving the price up of medication and driving out the independent pharmacy.
Right. And that seems to be something that I believe we should have a single payer insurance, but I don't think Medicare is doing a very good job of this. So, when I hear Medicare for all, I get violently ill. But tell me how that works in a pharmacy like yours.
Yeah, so like if we want to be available for a customer coming to use their insurance, it's managed by a pharmacy benefit manager. they present us, or they don't even, they tell you a contracted rate, and it's a take it or leave it. This is what we're going to pay you for the medications if you want to be in our network. Well, if you look at Rhode Island, there's really only 2 to 3 major insurances being carried in Rhode Island. So if I don't participate in that network, I'm pretty much not making myself available for like 30 to 50% of my market. So to operate a pharmacy and not be in network, it is literally impossible. But then when you're in network, your reimbursements are so low, it's almost impossible anyway. So as you can see, a lot of businesses are struggling.
Right. But the insurance companies all each have their own formulary, which at one time used to change once a year. Now, as a consumer, I'm going to tell you, my experience is they change once a week, almost once a month.
It is so confusing, and this is what I do every day, and I
Yeah.
still don't understand it. And these changes you speak of, I agree, and I don't know how to make sense of it either, to be honest with you.
Right.
I know the procedure to get it started, and then we just kind of hopefully wait for an approval. But beyond that, like I really don't know how to explain it.
Right. Yeah. And the reasons are not always okay. So the reason a person may need a particular brand over a generic is not necessarily medical. And I'm going to tell, well, at least not related to the drug. I mean, insulins, there's a little variation, and I'm going to talk about insulin because that's what I use.
Mm-hmm. Yeah.
Okay, so
it's a great example to speak of.
insulins, there are the long-acting, the short-acting, and within the class, there's not a significant variation. But in my case, I have hands that don't work. So if the plunger on the insulin pen is too difficult for me to use, then I can't use that brand. And that becomes a whole new challenge. So that's one of the things that we've run into. It's not an easy substitute.
And another thing, I'm glad you brought this up, but wrap your head around this. So say you need a short-acting insulin, and you wanted the Humalog. Maybe that was the best one to use. Mm-hmm. And the insurance said, no, you need to go to this brand, Novolog. Not only are you getting steered in that direction, because the insurance is PBM wants you to go that way, but it's also because the PBM on the back end is probably getting a rebate from the manufacturer. Right. Now think about this: if there's a generic available, say that would typically be less expensive, your insurance can potentially force you to go to Novolog. You have to pay a higher branded copay, and they're making more money in the back end. So instead of having like a $7 copay, you're going to pay $50 for a product that you don't really necessarily want, and then they're going to make more money off of that situation as well. So
right. So that gets really, really tricky.
And again, another thing to think about with insulin. I mean, you probably saw the FTC report, but literally they're in litigation right now, but millions and billions of dollars were made off of inflating insulin and prices to the consumer. Right.
And apparently the whole deal that had been worked out to have Medicare negotiate with pharmaceutical companies to keep the copay down has now been rescinded by an executive order from, I cannot make myself say the name, so it's a pretty scary time. But this is really very complicated, and I don't know. You're familiar with Cost Plus.
Yes.
And Mark Cuban's philosophy.
Yes.
And which is a really good philosophy, which is, like he has the bid in, so he's big enough to be able to negotiate directly with the pharmaceutical companies. But he's able to sell the prescriptions at a significantly lower cost than what is available now. And he is be able to negotiate, I'm sure by volume, and then he only adds a 15% markup. And so all of these other layers are kept out of the picture. So,
I like Mark a lot. I think I like how he stands on the topic. I think in the big picture, I mean, we got to look at sustainability with his model, and I think it's great. And I think you're seeing how much you're seeing an increase in price that we don't even know. It's like a big black box that it goes into, and then all of a sudden you have this price. You're like, wait, the cost of this drug acquisition cost is pennies, and you're charging me hundreds of dollars. So that's great. But I think it also, like, Mark Cuban's model is great for generic drugs. I think when you have to get branded drugs, and it just doesn't work along those lines. So there is some challenges along the way.
right, there are, but we also know that the drugs that are manufactured in the U.S. and have been through the FDA, which is all what they claim is the cause of the markup, and I'm just going to say they claim, those are the same ones that are sold in Canada
Oh yeah.
at way lower prices.
We pay the most for prescription drugs than any other country in the world.
Right. And that's something we need to be concerned about, because what Medicare does, and Medicare has been prohibited from negotiating pharmaceutical prices, and what Medicare does is just often copied by all the other insurance companies. So this is why I believe we should have a single payer insurance, but I don't think Medicare model is what we should have. I think that the healthcare system should be separate from the Congress, there's everyday whims and all of that. It has to be less, I think it has to be separate. And I think pharmacy part should have its own, freestanding competitive markets. And in a freestanding competitive market, prices do come down because they have to. And there's a concern about getting service, which is important. And the single payer does not any longer control the price.
Well, I think it's funny about Medicare. I remember when this came out, because I've been working in a pharmacy since 1999. You're coming out with a drug plan for seniors that is the most complicated plan. I've never seen anything like this before until Medicare came along, where you have these donut holes and coverage gaps and all these limitations, and it's mind-boggling for anybody. And then you're expecting the seniors in our community to understand or use this plan, and it's unfortunate that things are the way they are with Medicare.
Yeah, I mean, and it really doesn't make sense. And this translates into what's going on all over in healthcare. Hospitals should not be owning medical practices because they're driving away physicians. They're driving physicians out of the practice of medicine. They're creating significant harm. The things like durable medical equipment, especially this, which is considered complex rehabilitation therapy. The chair that I got, I'm going to say about 15 years ago, this is the same chair, same model. It cost, the list price on it was $30,000, which is a lot of money.
Yep.
This one, same model, I got it 2 years ago. List price, you want to hazard a guess?
I feel like I'm the Price is Right now.
$78,000.
Holy moly!
Yeah, same model, same chair.
That's crazy.
It has only one added standard feature, and it's the lights.
Oh.
So I don't think
They don't look like $30,000 lights.
No, they do not. Yeah, and so this is when we're talking people who are seniors, people with disabilities, people who are with chronic illnesses. These things become really important, and we're not the ones with all the money. It's the billionaires that are collecting it that are the problem here.
I think another thing too that's important to mention is the access to care, especially in our area here, and
Right.
how there's just not a lot of providers. And I don't know why Rhode Island has such a low reimbursement rate for physicians, but they're all leaving Rhode Island because they can go to Massachusetts and make a considerable amount more money.
Okay, so Boston's having a problem too. I, there was an article in today's Boston Globe about the number of doctors leaving medicine in the clinical practice of medicine in Boston because of the corporate structure. And then they've got, what, 9 hospitals closing because of Stewart's bankruptcy.
Oh my God.
And we have 2 hospital systems that, you know, if either one goes under, we are toast.
Oh yeah.
You know, and these are things that we should be concerned about. And I know if you can get to your doctor, you're lucky, and you're gonna say, well, I like that, but not everybody's in that boat. You know, there is a little known secret about Medicaid in Rhode Island, is that we don't necessarily need a referral for a lot of specialists, which does make life better. And there are still some physicians who are not owned by hospitals, but those that are, and even some of the larger groups that are not owned by hospitals, well, those that are very unhappy. I have lost 3 doctors in the last 2 years because of problems with ownership by hospitals. But you know, even those though that are not hospital owned, because of the size of the hospital owned practices, they're struggling because they cannot meet all of the same insurance complexities that you have to meet.
Mm-hmm.
So what would you like to see happen?
So
Let's talk about what you think would happen, what would make your business work well for you and for the people you serve.
yeah, that's a great question. Actually, I'm glad you asked that. So I think the number one thing is to get reimbursed at least for what the acquisition cost is of this medication. So we're in a position now where our contracts and our PBMs are paying us less than what the drug costs. So we're forced to dispense this medication at a loss. There's no other business that we're aware of where you have to dispense medication. You have to run your business at a loss. We don't have any power to change that without some regulation. So I would like to see us being reimbursed at a sustainable rate so we can continue to provide care for our community. When you look at the major change, when you call to ask a question about your medication, there's a lot of times you have to leave a voicemail and wait for that pharmacy to call you back. And I don't understand how that equates to good patient care. And these are, like, that's a decision by the pharmacy who is in charge of your reimbursement as well. So like they're creating this environment that's unhealthy and it's dangerous.
Yeah.
But I mean, I would like to see me able to service my community and not have to dispense medications at a loss for the business. Like it just, to me, it's the most frustrating thing. And what else is frustrating is I don't have the ability to tell my customer, I can't dispense this to you because we're not getting reimbursed by insurance. I can't say that to the consumer, or I will get my contract pulled by them. So I love being transparent with my customers. I think that's why we've been successful, is because we are straightforward with them, but I can't communicate that to them. So we're forced to keep these medications out of stock and not order them, and we have to play this fine line. So it's like, it's just backwards. It's so frustrating.
Yeah, no, it is. It's, and, you know, many consumers don't know that this part of it. I worked in healthcare for a long time. I am also an economist. In fact, I'm essentially an environmental and natural resource economist, but my work has been in the area of disability policy. I'm used to looking at things in that way. Um, and I see the struggle, and I see the struggle of the small practices. I see the struggle. I hear, for example, they're looking now, well, maybe if our public university has a medical school, it will solve the problem of primary care. And I think it will temporarily. But people, no matter where they get their education, if you're not able to practice medicine according to your Hippocratic oath, there is this issue that they describe as moral injury, because they're required by their employer to, treat people like widgets. You need to have 7 minutes off you go, and that goes against their training and their beliefs in why they are in the practice of medicine.
Right.
So that's not going to go away by turning out more doctors. You're just going to turn out more doctors who will eventually leave because it's impossible to practice under this, atmosphere.
Absolutely. Yeah, and it's the financial atmosphere that's being created too.
Right.
And I think you need to look at the value that certain, I would say, pharmacies bring to the community. Like,
Right.
what we bring to the community is we're doing deliveries for people who can't leave the house, or organizing their medication. We're accessible. We're providing vaccines for so many people in the community, yet we're not able to sustain a business because of big business. It's just,
Right.
it's extremely frustrating.
Right. Well, it is great that you can just walk in and get your immunizations, and it's easier to do that than to make an appointment and see your doctor.
Mm-hmm.
Certainly. And then there is one of the things that drew me to your pharmacy, other than my belief that we need small pharmacies, small businesses, is I saw, and it might have been on your website, about where Salis's used to be.
Oh, yeah.
I thought that was great.
Yeah.
That is a typical Rhode Island, how you give directions in Rhode Island. You go by where the old Rhode Island auditorium was, and you take a right, and you do, that sort of thing.
Yeah.
Knowing your way around. But that says a lot. That was, I thought, a really meaningful, phrase to have on there.
Yes.
That it tells people you belong here. You're here. You're part of the community.
Exactly.
And that's really important. And no matter what, and I know there are very good pharmacists that work at the larger pharmacies, but they cannot have that same connection to the community. And
it's sad. Yeah, they can't practice the way they want to, just like the doctors you spoke of. So.
Right. Yeah. Right. So, and that's a problem, and I hope we find a solution to it.
We need legislation that's not going to change without some sort of government, especially on the federal level. And it just came up in the last package that totally bombed when it tried to pass through. So it's coming back again in March. So we'll see if it gets. It's a bipartisan supported issue, which is encouraging. But at the same time, these PBMs are some of the wealthiest companies in the country,
Right.
So they're able to lobby behind the scenes and really get what they want.
Yeah.
Even if it's not the right thing, which is unfortunate.
Yeah, right. In this country, and when you're talking about this kind of legislation, and when you're talking about overall legislation regarding healthcare, and one other thing that we need to, I'll bring that one up, but again, I'm an economist, so there's a Nobel Prize winning economist called Amartya Sen. I don't know if you've ever heard of him.
Mm-hmm.
Okay, so almost all his work was done in developing countries, and I believe it's still ongoing. And he found through his research that if a country, no matter how poor a country is, not only directly but in relation to the countries around it, no matter how poor, if it provided two things to its citizens, that country grew its wealth and profitability and growth faster than any of the other countries around them. And those two things are the two things this country does not want to give its citizens. One is healthcare, and the other one is education.
Yeah.
And that is, and those are the two keys to having a growing wealth in a country, the country itself. And also, I mean, I know people say, oh, what is going to be my taxes? But if you look at the happiest countries in the world, they also have the highest taxes.
Yeah.
But they get so much more for their taxes. And if we got our health care and education, that would leave us much more spending money to spend on our, even though you think, oh, the tax, it's all gone in taxes, but you won't need as much, and you don't have to worry about those things. I'm sorry, I shouldn't have gone on to an economics tangent here. But it's so important. I mean, you're providing a really valuable service. And as I told you when you came in, my favorite pharmacy was another independent pharmacy. I didn't know that you had worked at it, but that there was an attitude of customer service.
Yep.
And it really, I found, very useful.
There's a personal side to it, and you could approach and have a conversation and really get the information that you need to stay healthy.
Yeah, right. Gee, what an idea, huh?
Yeah, can you imagine?
Yeah, right. So is there anything else you want to add?
I mean, it's been a wild 7 years, and I think the community has been amazing. The amount of people that have supported us has been great, and I'm really hoping we're here in another 7 to 10 years to have another interview.
Oh, well, we probably won't wait that long. How does that sound?
That sounds great.
Let's keep this going, because I think it is, you do provide real significant value to this community, and it's hard to find.
Mm-hmm.
So thank you so much for coming, and let's hope that we do this again very soon.
Yeah,
okay?
I would.
Well, thank you for listening. I think our guests really gave us a lot to think about. I'm Annette from Nothing Without Us. Stories and discussions of meaningful inclusion. If you like this episode, please subscribe. Please drop me a like. Make some comments. Tell us what you want to hear more of. In the meantime, if you saw that blackhead from this little dog vying for my guest's attention, that is my Kirby, who is my service dog, but who has figured out that if I'm recording, I am not going to stop him unless he's tearing the house down. So you got a picture of him as well. So tell your friends, please, about this podcast. They can find me on patreon.com/nothingwithoutus, stories and discussions of meaningful inclusion. I'm on YouTube, on Spotify and other audio platforms. You can also find me on LinkedIn and Blue Sky, and you can also check my sub-series, which is behind the paywall. It's open to people on the ally or activist tiers, and it's called Bitch on Wheels, where it's a little edgier, a little humorous, a little sarcastic. We have, I can be freer about what I say in short bursts. Till the next Nothing Without Us, I'm Annette.